The next talk, Dr. Tanvi, uh, excellent phaco refractive surgeon who's come into my practice as a, as a great gift. And she has, excellent cases to show you as always. So I wish you all the best, Dr. Tanvi.
Thank you. So today, the topic is think on your feet. There are some surgical steps you may want to change while you're doing it. And today I'm going to discuss two cases, one which I had to intervene and manage, and the second which I had to do it myself and think in a different way as to how would I do it other than my routine phaco surgery. So the first case, I've titled it as Too Fast, Too Furious, when speed in phaco becomes an enemy. Today I think there is this general feeling that if I do a good phaco, that means I have to be a fast surgeon. I have to operate in so many certain 7 minutes, 8 minutes or whatever. I think the speed or the amount of time you take to do surgery rather than what actually comes out as an outcome, that we need to reconsider what's important. Now this is a surgeon who's wanting to finish the case quickly. Each step has just gone on from one to the other without really making sure each step has gone well. Hydrodissection wasn't complete. He's still gone ahead and tried to rotate the nucleus. There wasn't a wave, so you can obviously see there's a lot of zonular stress that he's landing up doing, and then filling a lot of viscoelastic before every step. Now he's gone inside with the bevel down phaco, done a little bit of cortical aspiration, the loose cortex has been taken up, and without removing or using the other hand to sort of stabilize the phaco probe, he's also trying to rotate it so that he can start his nucleus management. At this point itself, you can see that things are quite turbulent. And then when the phaco starts, obviously the irrigation, aspiration flow rate is very high, the powers are high, the vacuums are high, and all of that is causing too much turbulence, and already you can see the iris has started coming down. Now at this stage also there is a chance for you to slow down, take a breather, and then do something different. But of course, we kind of become like Arjuna and we are only looking at the tip, maybe just the nucleus, and the rest of the tissue, how is it coming out, is it staying stable, all of that just goes out of our minds. And here again, there is a lot more viscoelastic being put in because obviously the iris is also wanting to come out. But the primary error that was happening is that he had already filled the anterior chamber a lot and then filling it more with viscoelastic, hoping that that iris stays inside. So now that iris had had enough. He was just being poked and poked and poked, and it refused to stay inside. So this is the time when we need to understand what is it that you can do. So first, you need to stop. Take a breather, literally for 10 seconds, take a breath in, breath out, and then realize that why is it that this is happening? So in this case, the incision was very shallow. It was not a well-constructed wound. So the iris, after many manipulations, had already started coming out. So now what I did was I set the iris back in its place, use a high volume viscoelastic. You can either do this from the side port. It is better to do it from a different incision than the main from which the iris has been coming out. And now obviously the plan was to complete the case. Since I wasn't the primary surgeon, I didn't know where the rhexis is, how large it is. So when there are these uncharted paths to cross, it is always better to do something which is going to give you good visualization and which will help take your path easier. So we put a pupil dilating device. You could use the B-hex. It's an excellent tool to use. This is the B-hex forceps, which can help guide the B-hex ring under the iris. All of this has been done under high molecular weight viscoelastic. You can use a spatula. You can even use a dialer to just sort of get the iris away. And then always stay in the capsule. Many times surgeons feel that, oh, already there's viscoelastic inside. Do I really have any advantage of using that stain again? But there is. Whatever little it'll stain, you will still have a better guide to understanding where the rhexis margin is and where you are supposed to work, where is your safe zone of working. And then, of course, make a new side, main incision, because that's what is going to take you from the end right till from the beginning right till the end. And here, I think the way we keep the phaco parameters are extreme importance. You have to keep the flow rate slightly less. Here I'm using the burst mode to do the chopping, so it's an 80-20 on-off time. The power is just as much as I need, nothing more, nothing less, depending on the grade of your nucleus. And direct chop probably becomes a safer approach rather than sculpting, because then you're going to cause less zonular stress. And by just doing this in that safe zone, you can see that the phaco probe does not move really to the periphery. It is staying right in the central 2 millimeters, 3 millimeters of a diameter of a circle, and therefore you can very safely keep the iris at bay. Another thing that I want to emphasize is where the irrigation ports of your phaco sleeve are. So once you're inside, make sure that the phaco sleeves irrigation ports are right in the center and they're not again hydrating the iris to get it out. And very safely, as you can see, the lens has gone inside and the B hex is removed, and something which was chaos could very easily become a clear and a good post-operative outcome. So just a few steps and things I would like you to understand from this case is that you need to know there can be an iris prolapse anytime during a routine phaco surgery, and there are certain pre-existing risk factors which our patient may have, but there are a lot more surgical steps that you may do differently that can cause this. So in our case, what had happened is that there was a sudden increased pressure gradient. There was a lot more viscoelastic that was inside. When the phaco started, the parameters were wrong. The wound integrity wasn't so good. The architecture of it was not composed very well. It was shallow. So all of this caused that iris to come out. So what can you do? You need to reduce that turbulence. Maybe you may even decompress the viscoelastic a little bit initially from your main wound. Make sure it's just the optimal amount that you need. Use high molecular weight viscoelastic. Use pupil expansion devices. Stain the capsule. Visualize it better. And then reposit that. So while you reposit the iris, also make sure you're not doing it too hard, because then you could cause a dialysis. And then use a separate, there's no harm in creating another 2.4 millimeter main incision. It's a clear corneal incision with a very low astigmatism inducing incision. You can always make another one right next to the one that is failed. So the take home points would be that do a good preoperative planning, and then of course if things don't go your way, do a better wound construction, control your fluidics, and I'm sure it will go well. So the next video that I'm going to show is of our own case, which is taming the storm. Now here was a patient who came with a phacolytic cataract. You can't see anything. The pressures were very high. There was already a leakage of the protein material out into the anterior chamber. We had controlled his pressures, but he obviously needed a surgery. And under mannitol, under getting the pressures as low as we could, we've started the surgery. So again, mind you, this is a case where you don't know what's under that lytic material. You can't see anything. So you are going to have to think on your feet as to what's next. So as you can see, when you decompress it with a side port, most of the lysed protein material is out. Then we have injected a high molecular weight viscoelastic, because now you need to do manipulations to go in, make the rexes, and then to deal with the hard nucleus. We can very well see it's almost grade 4, grade 5 nucleus, where most of the loose liquefied cortex is already out. So all the bag has is that hard cataract. So here it is important to go with that irrigating cannula and then to just wash that thick fibrinous material, mostly which is stuck into the anterior, into the angles, and then causing that glaucoma. So it's a good idea to spend a little extra time to just wash it. And then you set that lens back complex slightly back with a high molecular weight viscoelastic. And as you know that this lens is going to take a little longer than a normal phaco to operate, it would be a good idea to just extend that space and visualization. So here we are using 2 Y hooks to open up the pupil, but then also a good idea to put a B hex ring, because it will help you in the later stages of nuclear management. And with the newer B hex ring that has come up, you do get a larger visualization, more than what it was before. So this is what we do. And then you have to start thinking of how is it that I'm going to tackle the anterior capsule. And as you can see, it is a bit fibrotic, and you know that inside there isn't going to be any sort of a feedback, because most of the cortex is out and there's very little mostly present inside. So once you take a nick with a 26 gauge sharp needle, because that's how you're going to be able to cut, put a high molecular viscoelastic inside the bag. That's probably going to help you manipulate the rexes better. And then a nice idea is to just use an external light source like the light pipe, because many times the contrast of that color of the capsule in the background of the hard brown nucleus, it's not very well. So this external light source really helps you navigate where the tearing margin is, and then you'll be able to do a much safer rexes. If you're planning to do with a cystitome, it might be a little difficult because there is nothing to push back underneath. You may have to re-inject a high molecular weight viscoelastic repeatedly, but that's also something you can do. And in the end, as you can see, when you do a hydro dissection, there is nothing to dissect because it's just this hard, phacomorphic, or rather hard cataract, which is right there with no liquefied cortex. So now, when we do the nucleus management, we don't want the bag also to come around, and therefore to stabilize it, we decide to put a CTR ring, and this sort of helps expand the bag a bit. This step, you need to start thinking of how you're going to get your phaco-parameters on, because it's a hard cataract. You're also going to have to think of the endothelium, how much time you will spend in. Zonules need to be relaxed, not tortured too much. So the plan would be then to again do a direct chop. A vertical chopping mechanism is better. You could use the bevel down technique for a better capture. Once you hold the center, which is the thickest, you could either use a sharp chopper, but we have these blunt choppers which are slightly long and slender, and they work very well, and they're obviously safer. So by going a slow and steady approach, just keeping your cool, rotating as and when you want. So here again, we've used the burst mode with a lesser on time and more off time, but the power needs to be optimally balanced with vacuum. So the safest vacuum that you can work with, we've used around 550 and a flow rate of around 26 to 32, depending on how well versed you are with your foot pedal. This is what we use. And at the end, you can see that it is only the nucleus that has to be removed. And at the end of it, barely any cortex, but you can always do a bimanual irrigation aspiration for a safer rather than a coaxial one. And then implant the lens, get the B hex out, and the case is as routine as it could be. So the pathophysiology of these phacolytic glaucomas, we know that there is that leakage of lens protein which could cause flare cells and possibly fibrin formation, and we should anticipate that yes, intraoperatively there will be poor visibility, there may be zonular instability, and the capsule may behave differently than a normal one. So you need to be aware of these things and then plan. So the strategy would be to do a CCC, most probably with a capsule or excess forceps, because the cystotome may not be able to give you that kind of flexibility, and you should not anticipate much cortex. You will be wanting to use a CTR, so keep that in your OR in case of wanting to use it. For doing a phaco or a nuclear management, direct chop or a stop and chop if you're not well versed with direct chop, which just optimal low phaco energy and fluidics, you should reduce the turbulence. The nucleus cannot be moving all around. And then post-operatively, you need to manage this patient with intense steroids and NSAIDs, and then of course to manage the pressures with the help of your glaucoma colleague or giving them AGM. So with understanding what the cataract was, how it was, surgical planning can be done before, and we can definitely give them a good outcome. Thank you so much.
Thank you, Tanvi. Both the cases are very interesting. Now I want all youngsters who are into phaco to remember, the first case highlights a point which is very, very common. Hydrodissection, as simply put, although it's a very simple step to do, many of us, if I had some issues, we somehow kind of hesitate. And then when it comes to starting the case, we inject viscoelastic because the nucleus isn't rotating well, and we tend to inject viscoelastic sometimes little more than necessary. And once the iris starts coming out because of increased intraocular pressure, we forget that only that pressure can be brought down by going through the side port. That has been highlighted very well here. The more you try to push the iris back, it'll tend to keep coming repeatedly. Thank you, Tanvi. That point was very nicely brought out. And even in the second case, Dr. VC, you can definitely add if there's some point to be added. Those are the nuclei which are the hardest. So in managing nucleus, will you have a different strategy when it comes to such nuclei where all the cortex is gone, only just the hard nucleus that is left?
Yeah, I think that's the challenge that you have to face. The hard nucleus and bevel down, and a good chopper is a good strategy with a lot of viscoelastic in the bag. Behind the behind the nucleus also is a good idea. So keep on chopping and making smaller and smaller pieces, and keep on adding the viscoelastic from time to time to maintain the chamber and protect the endothelium.
Lovely. Thank you. Thank you, Tanvi.